Oops. Gotta find a better way to dispose of these bodies. Wish we lived in Vegas. Oh, hey. Didn't see you there. How you doing? Dr. Wilson, here to film another video for you guys and gals out there. We're going to talk about something that's new, but really not new, something we've been doing for a while, talking about immobilization, spinal immobilization. You guys may have heard rumor that backboards are just going to disappear. We're getting there. But first things that we have to do, we have to talk about where we've been, where we're going, what we're doing now, and not in that order, but we're going to talk about those things so that we have a better rationale as to what we're going to be doing when it comes to immobilizing our patients in the field. So really going back and talking about some history about spinal immobilization and where it actually comes from, it's very interesting. If you look back in 1966, it was discussed that patients who had trauma needed to be moved with rigid boards, and they should be immobilized for that movement, hoping to minimize continued trauma. Now, the key thing to remember about this is that it was really, the thought was to just take individuals, put them on these rigid boards, and move them from one place to the next. 1979, the American College of Orthopedic Surgeons actually then started looking at immobilizing patients based upon their neurologic findings. So if somebody had findings consistent with a neurologic injury, that individual, of course, needed to continue to be immobilized despite being moved with the board or with the cervical collar. And cervical collars came out of the whole realm of neurosurgical patients who were post-op from having their spines worked on, who then would be placed in these collars after their operations. So it was thought that using a cervical collar for an individual who had an injury would prevent them from having further neurologic dysfunction. So in 1984, the Department of Transportation actually then put the whole mythos behind immobilization into play by making spinal immobilization, full spinal immobilization, a part of the national curriculum for EMTs. And since that time, we've continued to take the injured patient and immobilize them from head to toe. And this took out the rationale for individuals to be immobilized based upon their signs and symptoms. It basically became a free-for-all that, hey, I got a fender bender, hit my car against a pole, and now guess what? I need to be immobilized. So if you think about that, it's not pretty rational when you suddenly see an individual who's walking outside of their car, looking at their car, screaming at the individual who crashed into them, going, what the hell did you do to my car? And then suddenly we tackle them, place them on a board, and immobilize them fully. It's kind of comical if you think about it. So that's where we've been. And when you think about it, it was the whole thing of being safe, and nobody wanted to be sorry. People didn't want to exacerbate individuals' spinal injuries after they had trauma. But if you think about it, without any symptoms of having a spinal cord injury or physical findings of having a spinal cord injury, no significant spinal cord injury exists. Inappropriate patients, by the way, inappropriate patients. And we got to think about what those patients will be, and we'll talk about appropriate patients in the future. And really, there have been no real reported cases of spinal cord injuries developing during appropriate and normal patient handling. So the old myth that we all hear, where we hear from our colleagues out in the field, where, hey, you know what? We took Mrs. Jones out of the car, and she was moving all of her extremities, but when we moved her and didn't put her on the board, she suddenly became paralyzed. That's a big old myth. So really, at the time of trauma, if the individual is not exhibiting significant signs and symptoms of spinal cord injury, they really don't likely have a spinal cord injury in the appropriate patients, and we'll talk about that. And if you look at certain things too, The spine board in itself doesn't really fit the rationale for immobilizing an individual spine. If we look at the curvature here, you notice that if you laid somebody flat on a board, this isn't going to immobilize the spine at all, in fact. So, we're going to talk about a few other things here, talk about where we are now when it comes to the use of C-collars and backboards. Okay? Let's go figure out some more stuff. Come on. So, where are we at? I'll tell you where we're at right now. If you look at most of the data actually shows that really, as I mentioned in the other room, individuals without having any evidence of neurologic dysfunction don't have a cervical spine or thoracic spine or even lumbar spine injury. So that's a good thing to know. So we can really be pretty judicious in the use of our backboards for those individuals. Now, once again, we have to have the appropriate patients, and we got to talk about who those appropriate patients are. Now, patients that would be appropriate to basically clear from a backboard, or not even put a backboard into play, would be an individual who basically has a GCS of 15, a person who's not altered in any fashion whatsoever, who does not exhibit any neurologic symptomology, who doesn't have any spine tenderness, and no distracting injuries. So these are things that we've been doing before when it comes down to cervical spine clearance in the past. But the big thing about backboards is they're not benign, so hence we shouldn't be using them as much as possible. Okay? Everybody gets put on a backboard for some crazy reason. If you think about them, they hurt you. That's the one thing backboards do 100% of the time. They cause pain. So in essence, try and clear somebody from a board when they have pain again, kind of hard to do that. So they get unnecessary films, unnecessary radiation exposure. And you know what? In this universe, you don't turn into a superhero with radiation exposure. You get cancer. So who wants cancer anyway, right? So also things that backboards do. Break down skin. They cause tidal volume to decrease. And one thing that's really important to realize is that backboards for penetrating trauma on individuals should be a big no-no. Okay, because actually it showed increased mortality with those patients. Now, we'll talk about that a little bit more when you look at the education on this, but just realize that backboarding somebody, you got to have a good rationale to do it, okay? We're not saying that the backboard isn't going to be used, but really, you got to have a damn good reason to do it, okay? We'll talk about that a little bit more. Let's go down this way. In 2013, the National Association of EMS Physicians, as well as the American College of Surgeons Committee on Trauma, came out with a position paper on spinal precautions and the use of the long backboard. Really, it kind of suggested that the judicious use of backboards be implemented so that you look at the risks and benefits. And this is where we're using that data to kind of move and advance our practice here in our system. So you'll learn more about that in the education. So just so that you know, we are moving towards a world where backboards may disappear. And you'll learn more about recognizing the rational use of spinal immobilization. So I'll tell you, this can sometimes be somewhat confusing and somewhat scary for people because we've had practice over the past 30 years where individuals have always been immobilized. But you know what? Moving towards the future, things do change. We have to advance, and we're going to advance together as a system. Thing is, we immobilize far too many patients. And the key to actually moving towards a future where we're not doing that is training, 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 and training. So we're going to keep on training on this. We're going to keep on learning about these things as we go into the future. If you think about it, it's not just training you as the paramedics out there in the field, but also training other medical professionals here in the hospital because it is changing a mindset. Because many individuals still think in that antiquated fashion that everybody needs to be immobilized. So we don't want to have you guys jacked around by folks here in the hospital saying, hey, they didn't immobilize that patient. You know what? We're advancing. They need to advance with us. So we need to educate them at the same time too. So training, 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 and training is more training that's going to need to happen so that everybody is actually on the same page. You guys are smart. You guys know what's going on. You guys know I trust you explicitly. And this is why I want to continue to make us advance to the future. I know we are a very, very progressive system, and I want to make sure that we actually continue to progress ahead of the curve so that we're not behind the 8 ball at some point. So take this education, learn about it, ask us questions because there are going to be a lot of questions you're going to have. But you know what? We're all going to make it through this, and we're going to be better for it, and our patients are going to be better for it. So let's go forward. See you guys.